Okay, we are live. Hi,
Hi.
I'm Dr. Shannon Clark with Babies After 35, and joining me is Dr. Nichelle Haynes. She
Hi.
is a perinatal psychiatrist in Austin, Texas. I'm super excited to be joining her. She's a new graduate, and so she's going to have a lot of fresh, new, exciting information. And, not that I don't, but I've been, a little older. So some of the information I have might be a little bit older. So that's why I wanted to team up with her. And this is what she does day in and day out. Perinatal mood and anxiety disorders is a very important topic, especially since this is Mental Health Awareness Month. And last week was Maternal Mental Health Awareness Week. So this is perfect timing. So thank you for joining me.
I'm so happy to be here.
If anybody has questions, I'm toggling back and forth between comments, and also each question we're going to address is going to come up on the screen. So without any further delay, you ready to go?
I'm ready.
Okay. So here we go. First question. What is a PMAD?
So
That's a new acronym.
PMAD, yeah.
Yeah.
So PMAD stands
PMAD.
for Perinatal Mood and Anxiety Disorders. So that can be a wide range of things. That can include depression, anxiety, bipolar disorder, manic episodes, and psychosis, or we would include OCD in the anxiety part of that as well.
Yeah, so my training, and I will freely admit, I did OBGYN and maternal fetal medicine. We're weakest in a couple of areas: nutrition counseling.
Oh, yeah.
Psychiatric care. And what was it? Preventative medicine, I would say. As much training as I did, those are the three areas where we did not get enough. So back when I was coming up, it was all postpartum depression, everything was postpartum, right? Mm-hmm. So what does the perinatal part of do you call it PMAD or PMAD? How do you guys refer to it?
I think whoever you choose, whatever you want to say.
So what is the perinatal? What does that mean?
So that means it can include pre-pregnancy planning, or during pregnancy, or up to a year after birth. But that can also be extended a little bit longer if someone is breastfeeding past a year. Yeah. So it's really that time that has big changes in hormones.
So we have learned, and we're extending that umbrella. We know, yes, everybody is pretty commonly known about postpartum blues and postpartum depression and all of that, but we are widening that umbrella to make sure women understand that it can occur before pregnancy, during pregnancy, and after. So, which I think is extremely, extremely important. I'm so glad that we're acknowledging that now.
I am too. I mean, a lot of women who have a postpartum depressive episode had symptoms when they were pregnant as well. And it can have implications for the development of mom, or, increasing risk of all sorts of medical complications.
And that is true. That goes for women with pre-existing mood or anxiety disorders, meaning they had a history of it before they even got pregnant. Those who developed it during pregnancy. And then all of a sudden postpartum, their symptoms may magnify. And like you said, they may have started having symptoms before they even delivered.
Yeah.
And that wasn't addressed. And now they're pregnant. Now you have the hormone, not only the hormonal changes, you have a newborn, you have lack of sleep, you have all these other stressors. And then it really comes to light in the postpartum period.
Right. Exactly. I mean, it's a stressful period on your body, on your psychosocial status. It's a very stressful situation, and it can have, implications for your mental health, of course.
I'll give a personal story. When I was pregnant with my twins, I was on hospital bed rest for 2 months. And that I know I got depressed then, but I considered it situational. I have treated patients that have been on prolonged hospital bed rest and stays for, my entire career. And then I was one of them. And then I finally understood. But I remember vividly, once I got home, then I became a NICU mom for 6 weeks. Then I came home with preemie twins. And then I just remember my mom was here, and I'm a physician, and I thought I was okay. And I lost it. I could not stop crying. I couldn't even come out of the bathroom. We had guests over, and I honestly did not even know what to do with myself. So yeah, I mean, it can occur at any time.
Right. And I think there's also something to mention here is baby blues, really common. What's the difference between baby blues and like a depressive episode? Okay. So that would be kind of the severity of the symptoms that you're experiencing could lead you more towards baby blues or towards a depressive episode. But also the timing. So baby blues should go away before about 2 weeks after delivery. And if it's not, then we would consider that possibly it's a depressive episode.
Depression, yeah. So timing is important, and we'll talk a little bit more as we go along about that. Next thing I wanted to talk about is, you're a perinatal psychiatrist. I'm a maternal fetal medicine specialist, OBGYN. So I'm taking care of women when they're pregnant, not so much postpartum because I see them for a limited period of time. So how can a woman know if what she is feeling is just what's supposed to happen during pregnancy and the postpartum period, or if this is actually becoming or is a PMAD? There's a lot of symptoms that kind of overlap. Right. And I hear from women all the time, well, my friend, boyfriend, husband, mom, partner, they just said, oh, you're just pregnant. This is normal for you to feel pregnant. So women hear that all the time from people in their support group or social circles. So how can they know if it's actually beyond that?
So I think there are some things to consider, like the big picture. So, first trimester pregnancy, it's normal to have some anxiety about, are we going to make it past the first trimester, especially if you have a history of miscarriage or something like that. It's normal to put it in context that you're probably going to have some anxiety or worries about getting to that next trimester, or maybe if you have a risk of early delivery or late term miscarriage, then it would be in context normal to worry about those things. In context, it's normal to be tired when you're growing another human. It takes a lot of your energy. It's normal to be tired. But if we put the big picture together, are you tired? Are you unable to do the things that you like to do? Do you have low motivation? Are you just not interested in the things you used to be interested in? Are you not getting sleep at all? Are you, at the end of pregnancy, you're up peeing all the time anyway. So you have to put it in context. But if you have a bunch of the symptoms that we would look for, then we might be worried. If you have maybe one, then that may not be so worrisome. Or if you have, one here and then one over there, but if they're all together, that would be concerning.
So I think the biggest takeaway is that women know themselves better than anyone else. And if they are starting to think, well, maybe something else is going on, then ask your doc, get some extra information to see if they can kind of tease it out and determine if it's beyond what's normally expected during pregnancy and the postpartum period. Would you agree?
Right. I think also, though, sometimes we're the last to know if we're depressed.
Okay.
So listening to the other people around us who say, like, you're kind of not yourself, or looking at how things compare to how they were before you were pregnant or how they were when you were feeling good can give you kind of a hint to say, maybe it's a decline from where you were before.
Yeah. So also listen to those people that are around you, like you said, and you're right. Maybe we are the last to know. I think in my situation, it was my mom who picked up on it. Yeah. And, listening to those around you, if they say, something's not right, or are you okay? Or, how are you feeling? And or they start to become worried, then take that as a cue that maybe we need to try to figure out what's going on.
Right. Right. And maybe it's one bad day, but maybe the pattern is what's important there.
Okay, here we go. All right. So this is a big question here. Why do women feel so reluctant to tell anyone, especially healthcare providers, that they are experiencing symptoms?
So, I could talk about this all day. This is our society devaluing our mental health. Yep. This is our society devaluing the experiences of mothers. This is sometimes poor experience with healthcare providers. This is, the healthcare system not allowing for enough time to discuss our mental health. So there's a lot of stigma about mental health as well. It's just a combination of a lot of things, which unfortunately led us to this point where there's a big stigma and there's just often not enough time to discuss mental health with your provider.
Yeah, and I agree. I was good about it before I became a mom, but I have since going through it myself and having a high risk pregnancy and all that. I try to really ask that question. I've been very surprised if I actually just stop what I'm doing and I get through all the stuff I'm supposed to get through. you know, X, Y, and Z, you know, she's in front of me. I just turn around and say, hey, how are you feeling? Or if I know she had something that she had lost a pregnancy in the past, you know, how are you feeling about that? I'm actually really surprised. It just takes one question sometimes for them to be like, oh, well, she's asking me, you know, so I'm going to tell her. So it's really worked well. Yeah. It's not like I'm sitting and grilling them about, you know, how are you feeling? Are you saying, no, sometimes it's just simple. A simple question. So I really try as a professional to do that myself. I know that's not done by everybody because of time constraints, and you have 40 patients to see that day. So how would you encourage women that if it's something they want to talk about and they feel like they're being kind of rushed through the 20-minute, 15-minute visit, what can they do to be advocates for themselves?
Always bring it up at an appointment. And if you don't have time at a certain appointment, make another appointment. It should be something that is a priority, because we know that this has bigger implications for your pregnancy, for your child's development, for your ability to breastfeed, for, you know, all sorts of important things that your doctor wants to know about. So really advocate for yourself. If you're not getting the time that you need, tell them, like, I need more time to talk about this. Another thing would be to find a therapist would be a great place to start. There's a lot of therapists and they designate their time. It's not necessarily about we're solving this problem at this appointment. It's we have this amount of time to talk about it in this appointment, and they can kind of guide you about whether you would need to see a medical doctor or physician for medication, because they have some experience in seeing you know, depression, anxiety, and kind of know when it's outside the realm of what therapy can be helpful for.
Well, yeah. And since you mentioned it, you know, I think another reason why women are reluctant to say anything to the doctors is I think they assume we're just going to say, oh, you're feeling sad, here's a medication. Oh, you know, let me just call that in for you. And it doesn't have to be that way.
No.
And, you know, if you feel like that's what's happening, you can say, you know what, I want to try something first. You can also call your insurance company. They should have resources for you as to which therapists are available, psychiatrists that your insurance covers, and get information. And even Medicaid patients, we have resources for that too. If you are a Medicaid patient, yes, it's harder to get in to see someone. I'm not going to lie. It's true. It is. But it doesn't mean it can't be done. It might take a little bit of extra work, but it can still be done. So, you know, advocate for yourself. Don't assume that we're just going to write a medication and see you back in a month. You know, if you don't feel like your doctor knows enough about it, and they may not, then ask to see a therapist or ask to see somebody else, in addition to the healthcare provider that's caring for your pregnancy.
Right. Exactly. I agree.
Okay. This leads into, why are PMADs so under-recognized and undertreated by the docs?
You know, even in psychiatry residency, we don't have much training on perinatal psychiatric issues. We just don't. So if you want to know about it, you have to go out on your own and learn about it on your own. Read the studies on your own. You don't really even get a lecture about this. It's kind of together where you can. So even the people who should be the most trained are not trained enough. So I think it goes back to education, stigma. I mean, the big healthcare system, it's a much bigger issue than one.
For sure. Yeah. I think it's lack of training, being uncomfortable with it. Not, you know, if I do ask this question and she says, yes, what am I going to do? And then lack of time. Also, if I, you know, I only have time to address 3 things, that may not be the one I pick, you know, even though that might be the most important one to her. So that's also part of the physician-patient relationship. You got to kind of decide which ones are the most important to address at that time. And, you know, so, you know, we can do a better job as healthcare professionals. Those of us that are not doing what you do, for sure, we all can do a better job. And I think that, you know, like ACOG and SMFM and that they're doing a lot more to try to bring attention to this, so that we are getting lectures available to us. Actually preparing for this, I went to ACOG's website. And for those of you who don't know, ACOG is the American College of Obstetricians and Gynecologists. It's kind of our governing body. And SMFM is the Society for Maternal Fetal Medicine. So that's for the maternal fetal medicine specialists. I actually went on those sites and there were lectures there, some really good ones. So I was very happy with that. So, you know, if there's any doctors that are going to listen to this who are taking care of pregnant and postpartum women, you know, we have to do a better job of educating ourselves, so that we are comfortable or we know who to refer them to.
Right.
Okay. All right. If a woman has a history of a mood or anxiety disorder before even pregnancy, and this is something that's in her medical history, and then she becomes pregnant, what should she be sure to let her doc know at that initial prenatal visit?
So I think it's important just to say that you have history, but also more detailed about that information. When was your first episode? How many episodes have you had? What does it look like when you have an episode? So we know what to look for. Because every depressive episode looks a little bit different. And what warning signs should we be looking for? What has worked in the past? How severe do things get? How do you look when you're doing well? Just kind of bigger picture. What does it look like for you? I think one of the biggest pieces of information I want to know is what's worked for you in the past. What hasn't worked for you in the past? As far as
and for most women who have had a history of depression, anxiety, or anything along those lines, they know which medications have worked for them, and they have an idea. And I have this as another question down the line, but we'll just address it now. One of the things I see as a high-risk obstetrician or maternal fetal medicine specialist is they have a history. They've been on a medication that has controlled them, and they've been doing well. They get that positive pregnancy test, and the doc, and sometimes it's psychiatrist, sometimes it's a primary care physician, sometimes it's, whoever tells them, stop your medications, you're pregnant.
Stop messing.
And I cannot tell you, I don't know why that still happens. And for anybody that's listening, please, that is not the answer.
No.
You want to elaborate on that?
Yes, I do. I really do. So that is really not the answer. The biggest thing about being a perinatal psychiatrist is I never tell anyone what to do. I don't tell you what to do. I will give you the information about here's the risk, here's the benefit, and here's the risk of untreated illness. We know that untreated depression in pregnancy carries a risk of miscarriage. We know that some psychiatric medications carry that same risk, and they're essentially the same risk, right? I will give you the information, and you have to decide what risk you're willing to take, right? So I think it's really important to know that there are risks of untreated illness. And sometimes the risk of untreated illness is worse than the risk of the medication that we're discussing. So,
and I'm just going to interject here. That is so true. And it's really hard to make, actually, sometimes it's harder to make the support system or the family member of the woman understand it more so than her, because she knows how she's feeling once she's been off that medication. And she might have that little bug in there, you shouldn't take it. And then it's, I understand it's family and you think they're wanting to do the best thing for you. But like Dr. Haynes said, I've been doing this for 20 years. And the consequences of untreated illness, in my professional opinion, far exceed any medication that you take that can make you feel better. When you're not taking the medication, and if you get depressed or have bipolar disorder and you start having episodes or you start having anxiety, the consequences of that for you mentally, physically, and emotionally, and on your pregnancy, not taking as good a care of yourself, not being in the right frame of mind, not being able to bond with your baby while you're pregnant because you're just not feeling well. Those consequences, and I'm not afraid to say it, are worse than taking the medication that's going to make you feel better and then help you be able to do what you need to do for your pregnancy.
The most important thing is to have a mom who's feeling good.
Right.
Whether that means being on medications or not. The other thing that we try to do is we try to reduce the number of exposures. So we don't want to go switching medications all the time. We want to try to find the medication that works for you. We also want to consider illness as an exposure. So we don't want to underdose your medication. Some people will say, like, I only want to take Zoloft at 25 milligrams or whatever it is, right? Like, well, now we're exposing baby to medication and your illness because your illness is not treated enough. So it's really important to look at the big picture here. What is the risk? What's the risk of medication? What's the risk of untreated illness?
And, again, I had this down the line in some of the questions, and we'll just, reiterate once we get down there. as far as the medication part, again, I'm maternal fetal medicine. This is my job. This is what I'm supposed to do, especially when it comes, I get a lot of referrals about women being on certain medications. Women do not question if they have a urinary tract infection or a kidney infection, or if they have diabetes or high blood pressure. They never question those medications. And honestly, across the board, those medications are not any better studied than a lot of these antidepressants. Actually, antidepressants are studied pretty well. And we have a lot of good information on those. So I want women to know that there is no medication out there that is risk-free, other than one that's actually, and that's what's called for nausea and vomiting in pregnancy. That's probably the one medication that's been the best studied in pregnancy over the years. But overall, that's why we changed how we classify risk of drugs. We used to do category A, B, C, D, X. We don't even do that anymore. We do it based on a risk-benefit ratio for that very reason. Because if we would tell a patient, oh, this medication is category C versus and this is category B, which most are category Bs. It always was a slippery slope. Now we don't do that anymore, right? No. So I think because of this reason. What's that?
I think it's better the way.
Yeah, no, for sure, because you have to weigh the risk and the benefits.
Exactly, I agree.
Okay, in pregnancy, we already talked about, there are symptoms that can occur just normally with pregnancy that can kind of mimic or contribute to someone who has a PMAD. But there are also some other medical conditions that can play a role as well. What might some of those be that can be related to mood disorders?
So a wide range. I mean, psychiatric illness, you should always have a medical illness as one of the differentials for the way a woman is presenting. Are we missing a medical cause of, like something that looks like anxiety? If someone has untreated hypothyroidism, it can make them look depressed. If they have hyperthyroidism, that can make them look very anxious. If you have gestational diabetes and your sugars are poorly controlled, you can look depressed, you can look anxious. Another thing with thyroid is if you're in a thyroid storm, you can look manic or psychotic. Vitamin deficiencies are really important too. If you're not taking your prenatal, you can get deficient in some vitamins and you can look depressed, or there's a whole bunch of illnesses that masquerade as psychiatric illnesses when really they're treated more with a medical cause. Right.
And, the thyroid is probably one of the biggest ones that I see, that anybody that's had a history or is telling me they're not feeling well, we always get a thyroid panel on them just to make sure we're not missing that, because I would hate to assume it's something and then it may be a combination of both. But, I definitely don't want to not treat something that's is also treatable, and can make things better for the patient as well. Okay, so let's talk about some risk factors. What are some of the risk factors for PMADs?
So the risk factors, I kind of stratify them in stressors and basically any stressor, right? So life stressors, if you have poor social support, low income, if your relationship status is kind of rocky, or you're kind of by yourself as far as support for yourself. If your pregnancy was unintended, that can be a risk factor. Of course, history of depression, anxiety outside of a perinatal period is one of the biggest risk factors. For postpartum depression, we always want to look for traumatic birth. I mean, traumatic birth can occur really frequently, and that's kind of defined by what mom sees as traumatic, not necessarily what was like a birth trauma as far as, tearing or risk to the baby. Let's see, what else?
Yeah, I mean, they're pretty much the same across. The one thing I wanted to mention about for postpartum risk factors is birth trauma. We don't talk about it. It's kind of, I don't know if it's a new thing, but it's maybe getting more attention. We talk about birth trauma. Of course, birth trauma is if you were physically injured during the course of the birth, no matter how might that be, or if the baby was, or if it was a crash C-section and everything went all to hell, for lack of a better, and you didn't, you didn't have any control over the situation, and Or if you were on hospital bed rest for 2 months and you were worried every day that you're going to lose your babies, that's traumatic too. So, there's a lot of ways that that the trauma can occur. And I think, one thing I want to talk about is that, for the people on the outside looking in, once it's all said and done and the baby's okay, you have this beautiful baby at home, everything should be fine, and you're still going through what you were feeling. And it's been 4 years, and I still feel I still go back to that place sometimes. The lack of control when I was on hospital bed rest for 2 months and was afraid I was going to lose my twins. The urgent crash C-section at 31 weeks where I was abrupting and didn't, know if they were going to make it. Being in the NICU mom for 6 weeks too. And I mean, there was a lot of trauma there. And, a part of me thought, well, I should be so thankful that they're okay. Why am I still wallowing in this, if you will? But I think it was traumatic, all the way around. So can you speak a little bit more from your point of view about that? Yeah.
There's a lot of societal reasons to invalidate the experience that we have as moms. We are given this message from society that we're supposed to lose our baby weight really quickly. We're supposed to be so happy in motherhood. There's supposed to be no things that we don't like about being a mom. We're not supposed to miss our old life. There's a lot of things that tell us how we're supposed to feel. And so we really invalidate the way that we feel about how the birth went. And the lack of control, I think you really kind of hit the nail on the head there. Is like the lack of control is really what can contribute to feeling bad. And there's a lot of triggers about a birth trauma, right? People come in, oh, how was the birth? Did you do this, that, or the other? Did you have an epidural? Did you blah, blah, blah? They want to know everything about it. And sometimes that's really stressful to talk about something that you're not ready to talk about. And then your baby, you have a baby, and that's a reminder of the trauma that you experience. And it's a constant reminder. And sometimes that baby's not that fun. Right. And so there's a lot of resentment, and there's a lot of things that we will harbor inside without talking about it. And it just kind of builds up. And if we don't release, or if we don't talk about or process our emotions, it can just sit there and make us feel so much worse. So another one of those things is like a bigger societal reason that we invalidate what happened, but it's a trauma and it needs to be treated as such. If that requires medication, that's okay. But therapy, talking about self-care, really important. Yeah.
And, I was in the hospital for 2 months and on the labor and delivery unit where I worked, and I was in room 9 for 2 months. I still work on that labor and delivery unit. And every time I have to go into room 9 I'm not even kidding you, I get a little panicked because it's just, I go into that room, everything's still the same way as it was when I was there 4 years ago. And it just starts coming back to me. So, I have to admit, before I went through it myself, I didn't really understand what birth trauma meant. Other than, if a baby was physically injured or a mom was physically, yes, obviously trauma at the, but what we're talking about, birth trauma, the mental and emotional aspect of it, not just the physical. Now I get it. Okay.
Yeah, and it's really one of those things that you don't really understand until you understand.
Yeah. Okay. So we're going to talk a little bit about bipolar disorder. We're talking about perinatal mood and anxiety disorders, but also bipolar disorder. It's very important to know about a woman's history of bipolar disorder, if what she's experiencing is bipolar disorder. Why is that so important to try to tease that out from it just being depression or anxiety?
There's a couple reasons that's really important. So bipolar disorder, in case you're not aware, is basically let's call this normal mood. And then we would have periods of elevated mood where you're not sleeping, you're feeling really on top of the world, talking really fast, moving really fast, maybe being reckless. So that would be a manic episode. And then there's also depressive episodes. So you only need one manic episode to be considered a diagnosis of bipolar disorder. A lot of people have several depressive episodes before they even have one manic episode. So if someone has a manic episode, that changes the way that we approach a treatment. So if you only tell someone about depressive episodes and you never mention the manic episodes, or you're not aware of them, or they haven't happened yet, if we treat someone with antidepressants, that may make them have a manic episode.
Okay.
And it's really risky. People lose their jobs, people sell their homes, people get themselves into all kinds of trouble during manic episodes. So those are really important to try to prevent if we can. So if you have a history of mania, we want to know about it so that we don't give you anything that can make your illness worse.
So, while you're talking about mania, explain again just what some of the things that would be a clue. I'm saying this because if you're telling your doctor for the first time that you are depressed and they don't ask you these certain things about your history, there's some of those things that could be an indication that it's not just depression, it's bipolar disorder. So you mentioned a few, but talk a little about what mania is like.
This isn't validated or anything, but my first question is usually, what's the longest you've gone without sleep? So in a manic episode, you can go on very little or no sleep for days at a time. So that's a good starting point and usually occurs with the manic episode. Of course, there's other things that you would want to know. Like, have you ever kind of had a period of time where you were reckless or not yourself or impulsive and doing things that weren't really like yourself? So those would be things that you would want to know.
So as a provider, that's something, or healthcare provider, that's something we need to ask for someone that has never really had a history or is presenting for the first time to us, to make sure that we're not missing a potential diagnosis of bipolar disorder. And then for the patient or woman coming in, if you have had a history of something like that, make sure you let them know. Because again, bipolar disorder and depression are treated differently. And what Dr. Haynes is saying is if we just assume it's depression and we treat you with an antidepressant, that could precipitate a manic episode and make it worse.
So we would use different types of medication for someone with bipolar disorder. Even if they're experiencing depressive symptoms, we usually don't want them on an antidepressant by itself to prevent that from happening.
So the treatment or the approach is different. The treatment,
the approach is different. The other thing that's really important for someone who has a history of bipolar disorder is that they are stable going into delivery, because bipolar illness puts you at really high risk for psychotic illness after birth. So a majority of people who have postpartum psychosis have a history of bipolar disorder. So if we already know about it, we want to be sure that you are stable so that we can prevent poor outcomes after delivery.
So going into the next question, what is postpartum psychosis?
So of course, postpartum is after delivery. The majority of cases will happen in the first couple of weeks, I would call the first month would be the majority of cases. Psychosis by itself is paranoia, believing things that aren't true, delusions, and then also hallucinations, either visual or auditory hallucinations, where you see or hear things that are not apparent to other people.
And that is a psychiatric emergency. That is something that needs to be addressed right away. And then one of the stats I had seen was that, like you said, bipolar disorder overall increases the risk of postpartum psychosis. And of those women who present with postpartum psychosis, greater than 70% will have had a diagnosis of bipolar or end up with a diagnosis of bipolar disorder. So and we don't want to be too scare people too much, but one of the reasons, many reasons, but one of them is that women who do enter postpartum psychosis there is an increased risk of infanticide or harming or killing the baby. And so it's very important as a family member, that I've had many family members who brought patients in because they didn't exactly know what was going on, and it ended up being postpartum psychosis. So it's very important that family members, if you're watching, that you pay attention to a new mom, and that, if they are having hallucinations, visual, auditory, anything like that. What were the other things you said for psychosis?
So delusions or paranoia, kind of like feeling like people are out to get you or having odd beliefs.
That
were not present before.
That needs to be addressed immediately.
So I previously was an inpatient psychiatrist, and this was something that I saw relatively frequently. It is an emergency, and you want to treat it as such.
Right. Okay. Then this is another great question, because women do not like to talk about this,
Mm-mm.
but we're going to talk about it.
Yes.
Okay. What are intrusive thoughts?
So this is one of my most favorite things to talk about
Good.
because intrusive thoughts are super scary.
Mm-hmm.
Intrusive thoughts happen to everyone, every person. It's basically something that comes into your mind that you wasn't related to what you were already thinking about. And during the postpartum period, oftentimes it comes up as accidentally or even on purpose harming your baby.
Mm-hmm.
So that can be something that moms don't want to bring up, of course, right? Because we all hear stories about babies getting taken away, or they don't, they don't want to say this scary thing. But intrusive thoughts, they really tell us that you're having anxiety, and they're not psychotic thoughts. And it's important to understand that every single mom, they've studied this, every single 100% of moms have intrusive thoughts. Common ones are like cutting up things in the kitchen and accidentally stabbing your baby, or the stairs are a really frequent one that I see, is like when you're carrying your baby down the stairs, or even if you're walking on a flat surface, worrying about harming your baby in that way. So intrusive thoughts can be a symptom of OCD, or they can just be being a human, being a mom. So it's really important to talk about them. It's important to just talk about your level of distress, how frequently they're occurring, if you're doing anything to reduce your anxiety about those thoughts.
Yeah, I have a friend who was had a child, had intrusive thoughts, but they were so affected her so heavily that it ended up being a diagnosis of anxiety. And it was severe enough for her that she didn't want to have another child. And that's a personal decision, but she had a really hard time, and it was a very stressful time of her life, and she didn't want to go through that again. And I completely get it. But she did seek treatment, she did seek help, and she got a diagnosis, and she understood exactly what you're saying, that it is normal. But for some women, though, it can go beyond normal. It can overwhelm them. It could be constant. It can be, affecting their ability to do things on a day because you're so worried about so much. And then that's where correct me if I'm wrong, where the anxiety is really kicking in and it's kind of taking control.
Right. So this is the way I conceptualize this, is like an aberration of a normal thought process. We are supposed to keep our babies safe. We are supposed to look around and make sure that we're preventing any preventable dangers. Right. So think about thousands of years ago, you look around and you make sure there's not a bear around before you put your baby down, or a snake, or whatever it was, right? So your body is supposed to look around and make sure that things are safe. And your body can go kind of into overdrive and look for things that really aren't going to be a problem. And so when they're really distressing, that's when it becomes problematic. Are you doing things? Are you not going up the stairs? Are you afraid to host your baby? Are you afraid to be around your baby by yourself? That kind of thing can kind of be clues to tell you that this may be an anxiety disorder.
Yeah, it's beyond just that. Yeah. Okay, so we could talk a whole nother session on treatments, but I just want to hear, for PMADs, you kind of break them down into mild, moderate, and severe symptoms, and you guys have lots of tools to kind of tease that out as to where each woman might fall, as whether her symptoms are mild, moderate, and severe. So without talking about medication, what are some of the treatments available when a woman is diagnosed with a perinatal mood or anxiety disorder?
So in general, for psychiatry, we have medications and therapy. That's pretty much all we have. In my practice, I kind of think of it in like a threefold way. There's medications, there's therapy, and there's kind of these ancillary things that we could do that will be helpful. So for mild symptoms, we may just need some designated time every day to have self-care. Take a shower, relax, take care of yourself in some way. That may improve symptoms if they're very mild. If we kind of get more towards the mild to moderate, we may consider adding in therapy. Although I'm a huge proponent of therapy, I think that there's not a person out there that can't benefit from therapy. If you have anything in your life that you would like to improve, therapy is a great way to start. So therapy, the ancillary things to add some more support. That's one of the biggest things that we can do to help moms is provide support. Another thing that is evidence-based is getting good sleep. I know it's really hard with infants, but ideally we're getting 6 hours of sleep in a 24-hour period. Even more ideally, those are together, but infants aren't on board with that all the time. So 6 hours of sleep can be restorative for our brain. If they're together, that's much better. Diet, of course, exercising. And then you could also participate in like psychotherapy groups are good. There are some free ones online that you could join, or in your city might have some too.
Yeah. So, the way I kind of see it or view it is that for mild, moderate, severe, basically, therapy is always an option for any one of those. Like you said, therapy is not going to, be bad for anyone. And when you start to consider referral from a healthcare provider standpoint, we should start considering it at moderate and then definitely do it at severe symptoms. As far as medication, we should strongly consider it with moderate and then severe symptoms too. So it's kind of how we think about it in a hierarchy when we're seeing a patient as to what treatment needs to be implemented. And again, treatment does not always mean medication.
No.
Treatments, there are all different types of treatment, including medications. So, there are multiple ways to treat perinatal mood and anxiety disorders based on the severity of symptoms.
Right. There's a bunch of things that we can do. It's not always going to medication. I have people in my practice, so I don't use medication. So
yeah. Okay. So along the same lines, when we already talked about it a little bit, when are medications recommended and what are the typical prescribing practices? Meaning what if we as healthcare providers are giving a woman a medication or have determined that she needs it, what kind of rules or goals should we have in mind with prescribing that medication?
So kind of along the lines of what we had talked about before, as far as when medications are recommended, is when you understand the risks, and the risks of untreated illness are greater than the risks of the medication which you would be using. That's different for everybody. That's different for, everybody's illness and the medications that we're considering. But again, if we're getting into a point where mom's bringing it up and saying that she's, concerned about her symptoms, that may be a time to consider medication.
I mean, and for us, what we kind of do is for MFMs, that those of us that are, doing it a little bit more than others, I always ask, have you ever been on anything in the past? What was it? And did it work for you? We always try to use the lowest effective dose, not the lowest dose. There's a difference. There's a lowest dose and there's a lowest effective dose. That just means every medication has the lowest dose, but that may not be effective. So we don't want to give you too much and we don't want to not give you enough. We want to do whatever is effective with the dose that's effective for you at the lowest dose. And then you mentioned this earlier, minimize switching. You don't want to, take them off and put them on something and then try that and then try this and that. You want to try to put them on a medication and keep them on. And while I'm talking about this, women have reached out to me on social media that had a PMAD, were given a medication, and then they say after 2 days I had to stop because I couldn't handle it. As healthcare providers, we question that because it's very hard for us to understand. And I also do my research is in pharmacology in pregnancy, pharmacotherapeutics in pregnancy. I know that that's very unlikely. That what period of time should a woman give a medication to try to work?
So I think it's different for everyone. If taking the medication leads to such severe symptoms that you can't tolerate it at all, of course, that's something that we at least want to talk about. Maybe we expect that to go away in a couple of days. Maybe we don't. But in general, the medications that we have work really slowly, unfortunately. So with the antidepressant medications, the antipsychotic medications, and the mood stabilizers, which is the three classes that we use most frequently, those take usually 4-ish weeks to know if they're going to be effective or not. And then we may not even be may not be at your effective dose. So if we start Zoloft at 50 milligrams, your dose may be 150 milligrams. So we may be looking
Right.
at 3 months before we know if that's the medicine for you. So we want to treat to symptom resolution so that we're reducing the risk of illness as an exposure.
Right. And then we're going to talk about this again, but I just wanted to also bring up is that, one of the commonly prescribed classes of antidepressants in pregnancy is going to be the SSRIs. And we'll talk about this in a little bit, but since we're here, there's been some thought, because of some of the neonatal effects, which, there are in some babies, that you should stop in the 3rd trimester.
Oh.
We're both going to tell you don't do that. And we're going to explain why here in a little bit. But as far as prescribing practices as healthcare providers, and whoever, if any healthcare providers are watching this, that is not recommended to stop them in the 3rd trimester.
No.
Because it's not beneficial for mom, and it can only make things worse in the long run. Do you agree?
I agree. So if we're to a point where we're starting medications for someone who is pregnant, we know that the illness is a risk, and we don't want to add in that risk at the end of pregnancy. Because if, for example, if a mom has bipolar disorder and she gets manic at the end of pregnancy, what does that mean? I mean, that could be very severe problems for her and for baby. So we don't want to stop medications towards the end of pregnancy. I think you're probably talking about neonatal adaptation syndrome for the SSRIs.
That's two more questions.
Okay, we'll get there.
Okay. All right. So we already touched on this, actually. If a woman enters pregnancy already controlled on a medication, should she stop it or change it because of the pregnancy?
No.
If you're already on a medication, and I tell my patients this, or tell women this, if you're already on a medication for any kind of mood, anxiety disorder, any kind of anything like that, it's better when you call to make that initial prenatal visit, let them know, hey, I'm on these medications. Because it might take a little bit for you to get that first prenatal visit. And if you tell them that, a lot of times they'll either say, you know what, I'm going to get you in a little bit sooner, or I'm going to go ahead and hook you up with a maternal fetal medicine specialist so they can tell you what to do. But don't stop your medications, please.
No.
That's not the time to do it.
By the time you have a positive pregnancy test, you've already exposed.
Right.
So don't stop just because of that. But definitely talk to your doctor about your specific circumstances. But we're only going to be adding stressors into our lives as we bring children into our lives. So it's not anticipated that your mood or anxiety disorder that you already had is going to get any better.
Right. And again, like I said, when you go to make that new OB appointment, tell them what medication you're on if there's a concern, because I promise you that doc is either going to see you sooner, or if they're not comfortable with don't know enough about the medication, they'll get you to see someone like myself who could tell you what to do with the medication. And sometimes if I can't, I'll tell by phone until I can get you in, don't stop. And this is for any medication. Okay. Right. If it needs to be addressed right away, we'll address it right away. Okay. So don't be afraid to let people know, let the docs know when you're calling to make that appointment, what you're on. So we were talking about what is known about antidepressants and birth defects or neonatal effects.
So I'll just start by saying the information and the way that we gather information about medications in pregnancy is kind of difficult because we can't do the studies that we would regularly do. We can't say, here, one of you take this medicine and one of you don't take this medicine. We're going to see what happens. And I'll interject here. What she's talking about, the highest level of evidence for studies in clinical medicine when you're studying any disease process is called a randomized controlled trial. That's where you have, I'll give an example. You have depressed women, and you say, you randomly choose. There's a this thing that can generate who gets what and who doesn't. One group of women's going to get the medication and one's not, and then you see what happens. You can't do that in pregnancy because you can't withhold treatment, and that's not ethical and that's not the right thing to do. So and everybody on social media and the ones that come after me, and I know they're going to come after me after this, and it's fine. Doing studies in pregnancy is not easy because you can't do a randomized controlled trial. Another way studies are done is you give, especially medications, you give it to people who don't have, to see how it's distributed in the body and what the dosage is. And you can't do that to pregnant women either. So most of the studies that we have in pregnancy on medications, any medication, is based on men and non-pregnant women. We are doing a better job of studying pregnant women,
but I'm involved in it. It's called the Obstetric Fetal Pharmacology Research Network. This is what we do. But I've been doing this since 2008 or 9, and it's taken a lot of years to build up and get that support so that we are able to better study women in pregnancy. So I'm kind of going on a diatribe here, but I want women to know that the reason why we don't have a lot of evidence is it's not because we're lazy and we're not one of the studies. No. It's because it's not easy to do studies in pregnant women because you can't expose them to anything that is, not something that they're supposed to be taking anyway. And B, you can't withhold treatment to study that. But those are the best ways to get study results. So you have to understand that's where we are, and it is what it is. So yes, that's my 2 cents.
Right. No, I agree. It's really difficult to have good information. And sometimes we have to go back and look at the outcomes.
Right.
And then you have so many variables which you weren't able to control for.
Right.
So did you happen to have one variable that was, contributory in one,
woman versus the other? Yeah.
It's very complicated. But when we do look at the information that we have a lot of information about antidepressants being relatively safe in pregnancy. Right. It of course depends on which medication you're talking about because they're all a little bit different. There are some that are preferred over others, but if the preferred medication doesn't work for you, we may prefer the one that's less preferred
right.
safe for you because it works. So we're not going to know that information until we try.
Right.
So the neonatal effects, which I think I was.
So I was going to, like, the neonatal effects that we're talking about is that there's in up to 30% of babies, they can be jittery or tachypnic, which means a rapid respiratory rate. That can happen in some newborns, but it's self-limited. It lasts no more than a couple of weeks. I know in our NICU or our neonatal department, if they know the woman has been on antidepressants, they watch the babies for that and take extra time and make sure that the kid, I call it baby kid. That's just my thing. Make sure the baby's okay. And they're aware of that and they do monitor the baby for that. So yes, that does happen. But it's not a long-term thing. It's not going to make the baby have respiratory problems or anything like that in the long term.
Right. It's self-limited, like you said. It should be about a week or less. And basically just means baby is breathing quickly or is extra cranky. And how do you really define extra cranky? Because that's what a newborn is supposed to do.
Yeah. And just we'll briefly mention the persistent pulmonary hypertension, which people might read about on the internet, or preterm birth or low birth weight. But those things also occur in women who are depressed. So, it's not, you could be on a medication and be well your entire pregnancy and your baby may have this, or you can be depressed your entire pregnancy and have a terrible pregnancy because of that. And your baby may still have it because you were untreated. Right. Did I say that right?
No, I agree. Yeah. Is the risk really the risk from the medication or is it from untreated illness? We don't even know if the mom was treated to symptom resolution or not.
Right.
In these studies. I mean, we just don't have that information. And like you said, we're not able really to get it. My suspicion is that it's probably related to illness rather than being on medication.
Yeah, I think in a lot of what we're going to find is that in a lot of medical conditions, that is the case, actually, not just in this. So, basically, yes, it's right to worry about your baby and what the effect of any medication, not just antidepressants, any medication might have on your baby. But we have to do what's best for mom, because if the mom is not healthy, the baby is not going to be healthy. And that goes into the postpartum period. If you especially for perinatal mood and anxiety disorders, she goes through her entire pregnancy unhealthy because of that, and then she has a baby, then she's a new mom and she's still feeling that way, it does have lasting effects on the mom and the child and the whole entire family, actually.
Right. So depression in the postpartum period puts baby at risk for several medical conditions, for delays in their development, for poor psychosocial development for them as well. I mean, there's bigger implications than just being on medications or looking at illness.
Right. So. And one little piece, if you're breastfeeding and you're controlled on a medication, stay on it. Okay.
So when we look at that,
Mm-hmm.
we look at relative infant dose.
Mm-hmm.
So something is considered safe when the relative infant dose is less than 10%, and the antidepressants are much less than that.
Right. Mm-hmm.
And you're probably getting less than they were being exposed to in utero.
Right. And through when you're breastfeeding. Exactly.
Huh?
Okay. We mentioned this earlier on, but we'll just reiterate this. What does it mean to say there is no risk-free decision when it comes to perinatal mood and anxiety disorders and taking a medication?
So really, there's no risk-free decision ever, right? There's risks that you take with anything. You can take a risk when you get in your car, right? You take a risk when you put your seatbelt on that it might cut you when you have an accident. You have to weigh the risk versus the benefit. Is this a risk I'm willing to take? Or would I prefer the risk of untreated illness? So there's no risk-free decision, period. I mean, you may fall when you walk out of the room right now, right? There's no decision ever that's risk-free. You just have to know what the risks are and have a discussion about what the risks are for your illness by itself and for the medications that are in question. And you get to decide whether you want to, which risk you're willing to take. Right.
Exactly. Okay, this is the last question. How can women be more involved in their treatment plan? How can they be, it's next question. How can they be better advocates for themselves?
Bring up anything that's bothering you. We don't hesitate to say, my back hurts when I get to the end of my pregnancy. We don't hesitate to say, I'm peeing so much more at the end of our pregnancy, right? We shouldn't hesitate to say, I've been feeling sad. I've been crying a lot. I have intrusive thoughts. I've been worried about this, that, or the other. So again, this is like a much bigger societal thing to say that mental illness is the same as physical illness. But if we were able to treat it the same way, our outcomes would be so much better. If we were to say to our doctor, whatever symptom that we're experiencing, I can't sleep, I'm not eating as much, I'm doing this, that, or the other, then we can actually have a discussion about how to help you feel better and how to improve things for you. So treat anything that you're experiencing as you would your back pain when you're complaining to your best friend. I mean, really just.
I mean, I think it's the best way I can explain it is that we are a whole being. It's not just the physical us. It's the mental us, the emotional us, the physical. It's all three of those things. We need to optimize the health of all three as women in general, as pregnant women, as new moms, because there is a lot we have to do as women and moms. And it is as myself and then, as a physician as well, it's not always easy. So we have to make sure that we don't just consider, I severed a nerve in my hand. I ran to, the doctor as soon as I had that cut. But why was I so hesitant when I was crying in the bathroom every day? So I'm a physician and I should have known better, but I did the same things a lot of my patients did. I just thought I should be able to handle it. Okay. So I know better now that it's so important that all parts of me as a woman and as a mom are as healthy as possible. And physical health is not more important than mental, and it's not, none of them is more important than the other. It's all, it takes all of it, all that to be optimized for us to be the best that we can be.
Yeah, I completely agree. And I'll add that our physical health suffers when our mental health is not adequate.
Right.
You don't take care of your eating as well, attend your prenatal appointments. There's lots of things that are, affected when we're not feeling good. And the difficult thing about mood and anxiety disorders is they try to convince you that you're not having any problem. When you're feeling sad, we invalidate how we're feeling. Oh, I have a place to live. I have food. I have this. I should be fine. But every experience that we have is valid. And we're just told that it's not.
Well, I think as women in general, I always tell my friends, friends and patients this, it's our nature to be fixers and problem solvers and all that sometimes we try to do that for everybody else but ourselves and our children, our spouse, our partner. And a lot of times we neglect ourselves. So we just, in general, we have to do better taking care of ourselves.
I agree.
Yeah. Mm-hmm. And this is the last question. What, as women, mothers, physicians, what can we do to decrease the stigma surrounding PMADs?
I think talking about it
Mm-hmm.
is one of the biggest things that we can do. If more women are out there saying or expressing what their experience was, then less people feel like their experience is unique. And when we see that 1 in 5 women is going to have an issue with psychiatric illness in the peripartum period, how are we not seeing that more
Mm-hmm.
on social media? Why are we not talking about that? How does it not have more awareness?
Mm-hmm.
Really just talking about it and telling people what your experience was can be helpful, because then other people will seek treatment too. It's kind of the snowball effect.
Yeah. Yeah. I think talking about it is, and it's becoming much better than it used to be. And I really applaud women who are very open and transparent about it, and the docs who are talking about it more and are willing to learn more about it so we can be better healthcare providers for women. So it's, it involves, more action on all of us, actually, for it to become normal as treating high blood pressure and diabetes in pregnancy.
Right.
It should be approached and dealt with exactly the same.
Mm-hmm. I agree.
So do you have any resources online or anything that you recommend that women can use if they don't have ready access to a therapist or anything like that? Is there certain things that you recommend?
So if you're looking for a therapist, a great place to start is psychologytoday.com.
I'm typing this in as you psychology. It's one word, today.
Psychologytoday.com.
Okay.
And it has, a whole listserv, a whole bunch of different therapists, and you can filter them by specialty, by gender, by zip code, by if they take your insurance or not. So you can start there. It's a great place to find a therapist if you're looking for one. And I think a therapist is a great place to start because there's just not that many psychiatrists, and there's even fewer perinatal psychiatrists. So a therapist can be a good first line of treatment. Maybe you don't need meds. Maybe therapy is the right treatment for you. And the therapist can kind of guide you in that decision. And I think that's a great place to start.
Mm-hmm.
If you're looking for more information, Postpartum Support International is a great place.
I was actually writing that one out. Yeah.
They're postpartum.net.
Postpartum.net.
Mm-hmm. And they have a lot of, for providers, for patients, little handouts or little pages on depression. Are you experiencing depression? Some resources that might be out there. And you can actually, I think, search their website for providers there too, who are certified in perinatal mood and anxiety disorders. So
so I have psychologytoday.com, Postpartum Support International, and I'm going to throw up the, actually I'll do this now. There's a telephone number here. Then there's also something called MCPAP for moms.org. And then there's actually an app called Lifeline. Make sure I had this right. Lifeline, actually for moms. Let me correct this. Lifeline for moms. It's an app that you can get on your Android or your iPhone.
Okay.
So that's another app that's available. I looked at it briefly and it looked really cool, and it has information and resources and tells you, actually you can kind of self-assess a little bit as well on that app. So it's a really cool app, and it goes along with the MCPAP4moms.org.
Mm-hmm. And also your OB is a great place to start too. They may have more specific resources for your area.
Right. So always start with your OB, and like I said, if there's a delay in getting to see somebody, or and I most of my patients are Medicaid patients and are indigent, and it can take a while to get into therapy or to even see a psychiatrist. So these are some of the things that I give them in the meantime, if it's beyond what I can do, or just as an adjunct while we're waiting or trying to figure things out. So these are all great resources. So this was excellent. I love this. I am so excited we did this. I think it was very informational, and I learned a lot from you. I think you're pretty cool doc. And I really applaud those of you who go into something like this, because we need more and more advocates for perinatal health. And so I really thank you for your work and helping our patients and helping our women be better moms and better, overall. So thank you so much.
I'm so happy to be here. I think my job is so rewarding because it's really not, it is about my patient, but it's not really about my patient. It's about my patient and her whole family and everyone else that's benefiting from what we can do and helping her feel better. So it's really rewarding, and I love what I do. It's so fun.
Well, it's awesome. And I wish we had more. I actually, as an aside, I work with medical students, and I think UTMB, where I work, is great at getting students interested in psych and primary care. And I'm always so thrilled whenever I hear that they're going, there's a large percentage that are going into those fields, because we definitely need more resources in that. So
I love UTMB for that. I trained there. I think they're great at, advocating for mental health treatment and getting a lot of people into psych. So
well, have a great rest of your weekend. Have a good Mom's Day tomorrow.
You too.
And we'll be in touch again. And if anybody has any questions, make sure there's no questions, nothing came through. This will be posted on my YouTube channel here. I'll also get it up on Facebook and on Instagram. So if you guys have any questions for either one of us, my social media is Babies After 35 on Facebook and Instagram. Your social media is her on Instagram is dr.nichelle. Actually, let me write this up so they can get to that. It's at dr.nichelle Haynes.
2 L's. E-L-L-E.
Yeah, I said it really fast. Okay. I typed it. I just didn't say it. Here you are. Yeah, right.
That's me.
That's her. So that's her Instagram. So you can get to her there. And she is located in Austin, Texas. If you're in that area, look her up.
All right. Thank you so much for having me.
Thank you.
Great. Happy Mother's Day. Have a good weekend.
All right. We'll talk soon.
Okay. Thanks.
Bye.